So, welcome everyone. Let me just say that just by looking at all of your profiles and what you do in your day job, I'm quite sure that what we're going to be talking with you, discussing with you over the next weeks. There will be aspects of what we say that will be very familiar. Our aim with this training is really to make connections and integrate different profiles of people, different thinking, so that our public health response and our health systems can be more effective dealing with the infodemic and actually consequently also managing epidemic risk. So this is actually how we approached also the challenge of the infodemic at the beginning of the COVID-19 epidemic, where actually really early on the WHO Director General pointed out we expect to fight an infodemic as well. We knew already at the beginning of COVID-19 from past experience, from Zika and Ebola, even HIV epidemics previously, that rumors and trust really influence the effectiveness of engagement with affected communities, and consequently also our ability as health authorities to manage the outbreak and the epidemics. So this is how we started last year, and I decided to start this conversation with you with a couple of key concepts and definitions. I will only pick on a couple, but this presentation is available for you in LMS and you can refer to it. So first of all, how does WHO define the infodemic? We define it as the overabundance of information of different qualities, both in offline and online spaces, that basically accompanies an outbreak. And this overabundance of information can also include myth and disinformation. And this is a very important nuance. And we will discuss this throughout today from a variety of perspectives. You're very likely are familiar with the term rumors. Rumor management is a big part of the efforts of the risk communication community engagement strategies. This is information, inaccurate or accurate, that is circulated within a particular network of people. The difference, then we have misinformation and disinformation. The difference between the two of these is the intent of the agent that is spreading the misinformation. So in the case of disinformation, misinformation is specifically designed and is being spread to achieve a particular agenda, whether it's for profit or political reasons, etc. A couple of other things. You will hear also about information overload. This is specifically a feeling that people have where they're being overwhelmed with information, and this can cause confusion, information avoidance in people, and that makes it also difficult for people to act on guidance on information that they receive. I will later discuss the information ecosystem, which is a really big concept of the exchange of information and communication in a digitized society, and it includes online and offline worlds. And I will speak a little bit later about information voids, which is a term that has really entered into practice over the last year, and it's basically describes questions and concerns on narratives, topics where people are seeking information about, but they cannot find credible information on that particular topic or narrative. And that is an information void, which is a precursor to misinformation and rumors. Now, we wouldn't be here in this training if we didn't all recognize that infodemics can cause real harm. This is not only about people taking unproven treatments or medications, which can lead to poisonings or even deaths. I have a couple of screenshots here. You're probably familiar with the overdoses with the ivermectin drug, for example, with poisonings with methanol, used early on in the pandemic in Iran, for example. But actually, there's other things that can happen. Health authorities need to spend their time debunking highly visible influencer spread misinformation instead of dealing with or managing the response. Or we have drug shortages or healthcare workers get attacked and harassed. So the cost of the epidemic is not only about the direct impact on people's health or the confusion and misunderstandings of the public health guidance. It actually has other consequences that are much harder to measure and connect. But I think they sound and you would agree with me that they're quite familiar and logical. So the infodemic can fuel mistrust, and not just in government and institutions, but also in science and expertise. And what's even harder for health authorities, mistrust in health system, and also in the public health response during an emergency. It can give rise to stigma, especially targeting vulnerable populations. And what I think is even harder to manage is the undermining of social cohesion, which then creates an even harder environment within which health authorities need to respond to an emergency. So you will hear about a variety of metaphors that we use to describe concepts in infodemic management, and touching the elephant is one. So perhaps and you're familiar with the Indian story about blind men touching the elephant. One touches the tail and they think it's a twig, and one touches a leg and they think it's a tree, etc. So depending on the perspective of the observer, we all can make different interpretations. So what we need to do is, especially when we are dealing with the infodemic, bring together all the different perspectives of touching the infodemic elephant and talking to one another. So interdisciplinarity and collaboration and really looking at the infodemic from different perspectives is really, really important. And this is not only about infodemiology, which is the science that is behind infodemic management. It's also about the professional practice, because there's no mistake that all of you come from different parts of the health system and beyond, also different parts of society. So we have vaccine demand strategists, we have risk communication community engagement colleagues, we have digital health and informatics colleagues, we have people that work with health information, and so on. That's intentional because actually managing the infodemic requires also different parts of the health system to take on the roles. What we've learned over the last year is that really what we need is, just like epidemiologists that have tools and methods and data that they use at different parts along the epidemic curve, that we actually do need to have and develop the same types of evidence-based tools, methods, and interventions for infodemic management. So this is a diagram that you're going to see a lot, and it was discussed last summer at the first Infodemiology conference, which produced a public health research agenda, specifically looking at how can we apply the current scientific knowledge and fill in the gaps to inform rapid development of tools that are practical for health authorities. We've also seen over the last year and a half high political interest and commitment by policymakers in addressing the infodemic and health misinformation, but also a lot of partnerships started. So I'm showing here just one of UN agencies at the UN General Assembly, but there's other partnerships with across society, with CSOs, civil society, the private sector, and the like. And this is something that is very encouraging, has been very encouraging to see. Then actually, over the course of the winter and through to February, we also realized that once we described what infodemic management could mean, then actually we need to determine the competencies that infodemic management, so that countries and health authorities could use when they began requesting people with these types of skills. And Liz is going to talk more about this and how all of this fits into a public health response. But what does that actually mean? So it's great that we have frameworks. It's great that we have competency frameworks. But really, you know, what does that practically mean? What does actually need to happen in a health authority process so that we can increase adherence to vaccine, to public health and safety social measures, to increase the demand for vaccines, and what is the role that infodemic management can play in these processes. So this is a diagram that actually you will see a lot during the training, but basically over the next sessions, we will take you through topics related to each of these 5 steps. So, and I will show a little bit later what we've learned in all of these steps, and we will slowly come back every session to one slice to start layering the insights and the discussion with you here. We've also, over the last year, invested quite a lot in training epidemic managers in order to support the increasing requests from countries. But really, you know, what we found was that the type of skill to support countries were very hard to find in one particular job profile or one particular person. So we decided to build a unicorn factory, and we emphasized upskilling existing public health professionals and augmenting their skills and abilities to do infodemic management. And Liz is going to speak later about the basis for the trainings. The inspiration was heavily drawn on the STOP training, and this really continues the tradition of really good collaboration of WHO, US CDC, and UNICEF in backstopping acute human resource shortages in countries. So the training that you're taking has been actually adapted by several countries and organizations to do their own infodemic management training. So until now, we've, together with partners, delivered 2 trainings. And as Sylvie mentioned earlier, you're part of the 3rd cohort. What we've also learned is that what we're still missing is a toolbox for infodemic managers. And this is really a toolbox that would be on par with the toolbox that epidemiologists use during the response. But, you know, the difference is that instead of having the decades to develop a field of practice like epidemiology has had, we've had months last year before the first COVID-19 vaccine started arriving to countries, and now with the continuous rollout, pandemic fatigue, etc., we are experiencing an intensification of the infodemic and bleeding of the infodemics together. So this is really what has happened over the last year. I don't think I need to tell you with how hard the pandemic has hit countries. The increasing pandemic fatigue has caused people to no longer adhere to public health and social measures or public health guidance. Cases have been surging, etc. So we really, over the last year have begun to reckon with the true cost of the infodemic on people's behaviors. And that's the tricky part. The infodemic, because it occurs in such a connected society, that especially because the society has also been digitized, the information flows and shifts really fast, it mutates, etc. It's really difficult to characterize the infodemic in an easy way. So it has societal levels, and it has the media plays a role. Then there's definitely impacts on communities and on individuals, and that's very difficult to measure and to imagine what interventions would work. Now, the last couple of years, the evidence base for the science of epidemic management has really grown. I think Lizzie has a slide later to show this, but needless to say that we do need to make sure that we channel that evidence into what is useful for us in health authorities. I'll pause here also with a thought that the infodemic is not only about COVID-19 or COVID-19 vaccines. When we really think about people's health behaviors or the cost of misinformation on health outcomes, here's an illustration of the fact that there is almost 6 times higher risk of death from colorectal cancer among people who use alternative medicine to treat their cancer. And this can all be related to false beliefs and misinformation. So when we talk about the skills throughout the training that you're gonna that you'll be gaining, this is something that we can pull into basically as a new perspective, a new practice in public health all around. Now, I'm really sorry, this is really a wordy slide. I summarized here our takeaway lessons from the last 22 months, from our own work and from work of our partners and communities. Suffice it to say, we really have rich experience from the response to the pandemic and how we experienced its impact, and it's really our responsibility to roll this experience and lessons into and point them into driving innovation and next steps. So we need to consider the fact that social determinants of health impact willingness of individuals and communities to trust health authorities. We need to consider what are effective approaches that we can take to manage the infodemic beyond the focus on messages and their amplification. And we also need to discuss the fact that health authorities have attempted to, those that have attempted to conduct infodemic management have actually found themselves in their own infodemic. It's really difficult to create processes that are agile enough in order to help inform in a timely manner activities that promote healthy behaviors. Now, I'll switch gears a little bit. If this was the experience of the last year, but how do we then explain it? And I introduced these slides for you basically for your reference. There's a couple of things to keep in mind of how society had changed before 2020 or the end of 2019 when the COVID-19 epidemic started. One is that especially in the last 5 years, 7 years, technology really changed the way that information is produced, distributed, and consumed. Technologies have always changed the way that we live, but really, we have changed a lot how we live. And that also means that it opened up almost a perfect storm for the infodemic to thrive both online and offline with this propagation of information going through the information ecosystem. But these discussions about how the society digitized society has changed us and how we live, these were not that, that had been occurring before. One thing that is really important for us to consider is that the way that we explain that in offline interactions, we all take up different identities depending on the context within which we present ourselves. Well, so is the case online. And this means that things that are important for us in the offline communication, actually, they have turned into vulnerabilities also in the online world. This is also a wordy slide, excuse me. But what I wanted to show here is that even in epidemiology and public health, as early as 1998, there were warnings about information epidemics and how they will, and how the internet and the evolving internet and connectivity may affect our ability to manage health information, to make sense of it, and to practice public health. So, and this was the era of social web 2.0. Now, several generations later, really, our information ecosystem has really changed, like I explained before. And of course, then the challenges that we all faced, or the Director General of WHO in 1980 faced when he, as he was declaring smallpox eradicated just before the HIV epidemic hit. Those challenges were very different, including the media and communication environment that we had was very different than the challenges that we all faced at the beginning of 2020. And, the way that we at the beginning of the pandemic were describing the spread of information, there was lots of unknowns about COVID-19. So we emphasized messaging and their amplification. This is how we explain the spread of information. But really, the reality is more like this one. The narratives continuously evolve over the course of the pandemic. And what makes it even more complicated, that how these narratives affect people's behavior. This depends on people's beliefs, on trust in institutions, and their connections with communities around them, online or offline. So what we're trying to look at with infodemic management is putting a person at the center and understanding their needs, their concerns, their questions, and what it would take for them to enact health behaviors. Now, all of that I showed basically also exposed over the last 22 months the challenges of the information ecosystem. So it's not just about health authorities, and it's not just about people receiving information about public health guidance. The science has been constantly evolving. That's a very different process than perhaps people have seen before. The publication, scientific journal practices have been different. The preprints, etc., that Sylvie mentioned, definitely had played a role in how misinformation was referenced. Excuse me. We've been challenged with at health authorities in distilling science, and then also as a whole how we communicate it, etc., etc. We needed to really look at, well, who are the trusted messengers that we could leverage, and really reflect hard, well, how do we achieve and maintain trust? And really the lesson learned here is that trust is a process, not an end state. We need to continuously take care of it going forward. Now, this is a busy slide. I actually added it for you to read at home. But this is an infodemiological model that myself and Terry Zempt, a colleague from Australia, put together to basically bring home a couple of points. We often hear that information is the problem. The information traveling through social media or through radio or any type of social network. Actually, the agent of the infodemic are people and people-made technologies. Why is this important? Because our behavior, people's behavior, is the one that propagates the infodemic. And in addition, if we think about information as thoughts and feelings that we feel, and that we have a particular interaction with. That can inform also how we then can explain what makes people behave or enact a particular behavior. What am I saying? We've basically known, and a lot of communications colleagues I've spoken with over the last 2 years have explained to me how really media and communication studies have several decades ago already concluded that just providing information to people, messages to people, will not change people's behavior. It does not actually have the desired effect. What we need to look at is how often, for example, these messages are delivered. So the pace of the messages, or the genre to which the messages are delivered, or the medium through which they're delivered. So why is this really important? Because the same message will have a different meaning to people if they think that they're watching online a news program versus a comedy show. And also, their perception of that information moves too fast is related to that. What I wanted to just point out to you here is that if we then consider the information ecosystem from that perspective, and if we then consider, okay, if the agents that propagate the infodemic are either technologies or people, then we can look at, well, people who are alarmed, who are socializing, who are confused, and they may be using different tools to propagate the infodemic and information. So online, it's something that is perhaps more familiar to us, platforms and technologies, etc. But the offline tools as well of propagation of the infodemic. So this is for you to study, but it's very rich slides that Terry allowed me to borrow for today. So with all of this said, what we really postulated over the last year and a half is, well, what are the policy options for health authorities in the absence of firm, while we're still studying and generating evidence for different interventions? Well, what is the current experience from managing the infodemic, and what are the policy options that we can currently take? This is the 6 that we've been that we've put forward. And it all really starts with understanding the concerns, the questions, and the identifications of people. So we really need to think from the point of view of how do we triage the populations and vulnerable groups to determine who is most and least convinced in their position, and then we begin with those that are least convinced. And then really try to define strategies to address those. And really, the interventions really are not just about communication. We may need to be ready to consider interventions in changing health service delivery, design, or other policy changes that need to be done. Of course, being able to and investing into distilling science and communicating science, working really with thinking outside the box about who the trusted messengers are and amplifiers in communities is really important. And you will hear about this later on in the training, as well as building resilience to the infodemic and health misinformation. So we're back to this diagram. And what have we learned over the last over the last year and a half? I summarized here a little bit. And you will hear this starting tomorrow, on Thursday. There's the first session that specifically looks at social listening to understand the public's questions, concerns, and narratives and misinformation. What you've heard, for example, what you've learned, for example, in the social listening sphere is that we really need to create integrated analysis plans that are actually based on the needs of the programs that will use the data, not on the types of formats of the data, for example, that we collect. For example, we've also learned that we really need to be tactical in how we communicate when we deliver high quality health information programming. So that's for example, promotion and support of resilience and healthy behaviors and community engagement. We've learned that community engagement is a continuum, and that different forms of community engagement will have different impacts in different contexts. And we will discuss all of these lessons learned over time. We've also, as health authorities, had to build new and extended partnerships. This is something that I wanted to acknowledge. It's been, and you know, we as health authorities do need to interact across society in order to drive change and insert the health considerations of the infodemic in other policies and discussions across society as well. I summarized here, looking forward, are thinking about what we need to do now, like in the next 6 to 9 months. And you'll see that the focus is very much about integration, about application of science into tools that are practical to countries, development of viable policy options for policymakers. And, you know, of course, one does that only with really subnational and useful insights that are sustainable and feasible to generate over time. And not to underestimate, we need to be creative, really thinking outside of the box, how we collaborate, who we involve, how we do implementation science, how we strengthen systems, how we integrate into the health system and other systems going forward. The last couple of slides, I did want to emphasize a couple of these things. So I've already mentioned to you really the need for us to work across disciplines and across professions in the health system. This is where we are today. This is where we are in the training as well. And I'm really happy to have such a diversity of colleagues from which we all can learn from each other going forward. We all need to touch the elephant from our own perspectives. What's also very clear is that we need to invest in, especially in those actions that we can, as health authorities, that we have more of a degree of influence over as health authorities. So I mentioned information voids. We really need to proactively anticipate what people's concerns and questions are, because then our communications efforts will meet the needs of the people at any one point in time. And if we do this, we can actually preempt, we can fill in the space of tension, of information deficits by providing reliable information. And this is really low-hanging fruit that every health authority should be able to address instead of just chasing mis and disinformation and rumors. It's also very important, and this is very difficult for us who have been in the response now for a long time, is that while we are working in the response, we're firefighting. We are really really focusing on responding to the emergency as the house is already on fire. But we do need to, at the same time, really start thinking about strategy and resilience and preparedness. So we need to also put on the other hat of being a fire marshal, thinking strategically. And this is why you will see throughout the training, we will highlight what we need for preparedness and what we need for strategic thinking, resilience building, and systems building going forward. This should be a no-brainer. We really cannot have one blunt tool that will be a solution to everything. We really need to find and understand the nuances of what kinds of tools we need to use in what situations. And also really consider how the different tools are implementable in different contexts, in different terrains. Now, this is not only and actually related to whether or not countries are high, middle, or low income. Because actually the size of this toolbox that we can use for infodemic management actually relates more to strength of systems and capacities than anything else. And we will be challenging you to think through maturity of infodemic management and integration into the system throughout the training. I mentioned already that because infodemic management as a practice is still evolving, we still need to test a lot of interventions. We need to test a lot of analysis approaches, methodologies, etc. That means that we need to, as we work, actually also use implementation research and other systematic approaches that will help us inform and very quickly find out what works and what doesn't in our context, and then share this information and experience with others so that they can adapt and transfer the knowledge going forward. And then lastly, this is my last slide. What I wanted to mention here is because maintaining trust and relationships with communities is increasingly important. We really need to consider the strength of engagement between health systems and communities. So I like to actually describe infodemic management as really at the frontier of the changing nature of public health practice. Because if we really want to manage the infodemic, we will need to make sure that the ties and between the health system and different population groups, with patients, with the public, actually are trusted. But that means we all will need to, through different parts of the health system, contribute to this. So I will stop here. Thank you very much. I will, because I know that I've spoken a lot, I would suggest actually a list that I look through any questions in Slido and answer them in writing. And in the meantime, we go for a break so that everyone can stretch, maybe get a drink and get up from the chair, and then we continue afterwards. How does that sound?